Colleagues, after yesterday's very productive and very intensive day, people are not really eager to start that early at 9 a.m. on Saturday, but we were supposed to start the meeting already. Therefore, I would suggest to start our first satellite session. It is educational symposium with the support from the company Johnson & Johnson. And it's dedicated to the issues, to the accessibility of the pharmaceuticals. And representative of the company, are you here? Can you join me on the stage? We are expecting from a representative from the SK Pharmacy. And can you please, dear speakers, join me on this scene stage? And representative of the Ministry of Healthcare, Mr. Kash, can you also join us on the stage? Oleg Shakharich, I think that he is not here, or he is outside. Well, let us figure out where he is. We are waiting for you, Mr. Olenbeck. Unfortunately, some of the speakers were not able to join us. Ardak said that he was supposed to be joining, but unfortunately he has some urgent matters to attend. Therefore, Mr. Ulukbek is a representative for the Ministry of Healthcare, and some of the other departments will be joining later. And I think that in the process of this session, we will have more people to join us. And it's not really easy to start working day on Saturday. In addition to that, I would like to introduce participants of today's session. Moderator of this session, that is myself, Alexandra Kostyuk, advisor to the Association of the HTA. We have the director of the Department of the Organization of Medical Assistance, Mr. Ulukbek, the head of the Johnson & Johnson Kazakhstan, Mr. Adlet Nazarbayev, the head of the Johnson & Johnson's Department on Emerging Market Access. We also have Mr. Janat Zhirenova and the head of the Reference Center for Pricing, Ms. Janat Bekova. Well, now we have some other colleagues to join us from SK Pharmacia. Let's start today's session. The plan is that we will have some speakers online. This will be the head of the Association of the Manufacturers, Mr. Vyacheslav Lakshin. Vyacheslav, can you hear us, or are you not yet here? He hasn't joined the session yet. I believe that he is logging in, and he will be joining us during the program. Well, dear colleagues, today's session, we are planning to discuss different aspects. The plan was to discuss the increasing costs, current challenges, and possible solutions in the context of our country and Kazakhstan are possible in this regard. And also, I would like to go to such an aspect. Yesterday, in one of the presentations, or even in several presentations, during the first non-conference, it was about accessibility, that not enough Kazakhstani data is available. Some issues were discussed at the level of that in some years there were some PNQ discussions for European manufacturers, but data was not very deep. And today, the relevance is about similar discussion in terms of the duration, how long it takes for the patients to get access to some of the medicines. Well, we are looking also at the sources, at the essence of this problem, what are the root causes, because if we know what the problem is about, it's easier to find a solution to this problem. Well, just a brief information about for the participants about the first study in our country, about the how accessible this is for our patients. HTA Association of Kazakhstan was facilitating the study. I was an independent consultant on design of the study, on assessment of the findings. And now let us move to the presentation. Do we have the slides? Since the session is in the format, since as our session today in the format of a discussion, well, we probably will not go to the tribune. Let me continue from where I'm teaching now. While this study was conducted, Kazakhstani researchers looked at the similar approach used by European Union, where it was about structuring of the types of accessibility, and in line with that, there were three options. This is a full access, where it is possible to have it compensated, or full automated compensation via the budget of the hospitals in terms of affordability. Partial affordability and accessibility for types, it's partial subsidies for some subpopulations, some partial compensation for the national list of patients, and limited or partial compensation with the delayed decision making, and also accessibility or affordability. It's called management entry agreement. Well, as of now, some elements of the partial compensation is a possible option based on our healthcare system, and there are also options for the full compensation. We cannot extrapolate European system and Kazakhstani system completely, but we probably all know that we have the list of the medicines on the national level, also from list from the distributors, and we have the list for the free of charge medicine for outpatient care. And it is in line with the healthcare system of the Republic of Kazakhstan. We have Kazakhstani National Medicine Formulary. This is a basis for the procurement. Based on this list, we have the list for the single distributor who procures it, and also for outpatient, it is free of charge provision and distribution to the patients. We should understand that Kazakhstani formulary is not an analog, or it's not the same as it will be procured by the single distributor. These are not equal definitions or equal provisions. The list coming from the Kazakhstani formulary is a possibility for the hospitals to provide such medicines to the patients, even because this is not in the list of the single distributor or in some other list. If it's in a part of the Kazakhstani formulary, based on the local government decision, it is possible to provide such medicines to the patients. Well, but it's also about our national context. It is partial access because there are a lot of factors impacting accessibility. It's also about the financing level in the regional context, and there are some other factors. Sometimes it's even a human factor, I would call it, which is at the level of the execution branch of the government. Because in every region there are different amounts made available for the financing. In some regions, we can say that it's a sufficient level for the financing of the coming from the local budget for to ensure accessibility. But in other regions, this might be very small budgets. In our national context, it's not really about the complete access or full-fledged access. For they are available if they are in the list of the single distributor, but for the outpatient level, if they are in the list of the free of charge outpatient medicines list. And for this medicines, they are also, if they are included into the free of charge outpatient medicines, they are in the list of the single distributor as well. And this is a new development of recent years. While some medicines are in the list at the national level, they have the special mentioning in the order from the Ministry of Healthcare that they are supported from the local budgets. Well, we used quite a holistic approach, but we decided to compare the data from different countries because it made no sense to look at the FPA only, especially in the European region. Well, you look some of the data coming from the EU and the European region. Well, we compared them to the local data available in Kazakhstan. And as you can see, based on this context, as referring to the ranking of the accessibilities of complete access based on all the registered medicines from 2013 to 2022, it is only made available to 24% of the medicines. It is about the drugs. It's L01, L02, mostly for therapeutical medicines. And partial accessibility, it is only for 57% of the medicines registered in this period. And in this situation, we can probably say that overall the picture is different, and it's as you can see, for the majority of the European countries, it is with a sign of minus. Well, it looks like we have quite a good segment of the partial accessibility. But well, since we said that at the regional level, it really is quite diverse. Therefore, it is a variable with very big uncertainties. How this 57%? Yeah, formally it might be that, but in practice that might be something different, which is without ensuring such access to the patients. Well, you see that 19% of the medicines registered in this period have no compensation within the mandatory obligation mandatory insurance schemes or some other state guaranteed volumes of free of charge medicine. As you can see, in Germany, it's 98% of the complete accessibility. As were said, yes, it was said yesterday that reimbursement in Germany takes really short time. But just one thing we should bear in mind, that Germany is actually the only country in EU which within its social system of medical insurance is financing medicines as soon as it is available on the market. right after registration. And if to be candid, well, the key focus of our conference, why we are looking at this topic, Germany has also the HTA, including the reimbursement for the medicine. Germany has a parallel exercise of HTA, which takes from 6 to 9 months for the medicines. Well, it's a possible situation, but this is a dynamic figure. When it's said that German people are are so great that they start financing at once, but well, they say, well, since we don't know if it's a good or if it's a good medicine or it's bad, we will be financing it. But after HTA is made available, after it's over, depending on its findings. If the findings are negative, then the drugs are no longer reimbursed, and it takes something like from 6 months to year and a half for a complete reimbursement, and then based on the HTA result, the decision is revised or revisited. Well, to be again open, patients will not understand such approach when for a year and a half we will be reimbursing and then we stop it. Patients will not be happy about that. Therefore, it's not really, like an applicable system for Kazakhstan. Bulgaria, Portugal, Slovenia are economies similar to ours. While overall about the level of accessibility, even the countries with similar economies have wider access and better affordability. This is a good analytical material, and based on this data, we will be having a follow-up steps, and we'll be moving forward based on this research. Well, now you can see how it is distributed by the years, or how. Unfortunately, we don't see the whole slide here. On the left there were years. Those are the medicines which were included into the list of the free of charge medicines made available through the outpatient list. And you can see 22 drugs in this list. After that, just one additional medicine or drug was included into the list. I'm not sure why we don't see these slides properly, because we don't see the years. Just please make a note, the team who edited the slides. Well, if you remember, in 2021 and in 2020, we have the insurance scheme introduced. This were the years when new medicines were included into the list quite actively and proactively. Here we see possibility for registered medicines to be included into the list, but also some of the medicines are included into the reimbursement list even before they are registered. You see the chronology, you see the timeline from 2005 to 2022. How the list was expanded for the L001002 list for the oncological medicines in Kazakhstan. Some of the medicines are even not registered. 2 medicines in 2006, 3 in 2009, 2 in 2011, 2 in 2012, 5 in 2013, and 1 in 2020. Well, as it's in international practice, majority of the medicines are registered, and this is not about how it works in realities of Kazakhstan. This is also in the international context. It's a marketing tool, how to simplify and facilitate registration. But in Kazakhstani system, it's also a possible option for some medicines to be included before they're registered. But as you can see on this slide, just an illustration to my previous slide, after the insurance scheme, we can see actual stagnation to the in terms of the access to innovative medicines. There are objective and subjective factors which are causing the situation, but we will elaborate on that later.
We have analyzed the standards as well as the standard approach that the European Union is using during the study. It's starting from the registration beginning and up to the reimbursement. In our case, we are going to cover the outpatient because the national formulary provides only for partial reimbursement. And you see the trend year by year, how much the period took from the moment of registration. And you see the list starting from 2005 until it was around 500 days. Then it was fluctuating and varying. On average, since 2012, the consideration would take from 600 to 400 days. Apparently, you see that starting from 2020, we see an increase after a general stagnation when there were only 2 drugs included, but they were included with the waiting time of more than 3,500 days. As a matter of fact, this is too long. Maybe they were included in 2020 because it took them maybe 10 years before they were included. And comparing and contrasting it with the overall failure of access since 2020, we see that a large number of drugs registered in the last 5 years, including highly effective drugs to treat oncology that are widely applied across the world. For this reason, unfortunately, they are unavailable for the patients of our country. Well, over here, you see a summary table about availability of oncology drugs that compare all parameters of accessibility. So it's the cap price, inclusion into a different list, like the national formulary. And here, because of the change of since 2005 through 2023, as we were comparing it, and the limit prices, price caps, its inclusion of the drug into the national formulary and limit prices and the outpatient list. So unfortunately, the statistics is not positive over here. So taking into account what I've said before, we have analyzed the analysis of the reasons for the access delay for new drugs of patients, and we have come up with the findings of our analysis. So we've tried to structure these drugs, these reasons, into 6 categories: those that are equipment related, process related, people related, material related, environment related, and control. So one of the reasons that I would name over here that is being addressed but has not yet been successfully resolved is lack of automation of the inclusion process. Another reason that hinders the consideration of the drugs is absence of an independent healthcare institution that would review it all, because the global practice shows that in the countries where they have this independent entity for assessment of healthcare technologies, and when there is a, like we've discussed it behind the stage, there are no, then these countries have no gaps in consideration and decision making because these processes are interrelated. Unfortunately, this stereotype prevails that a formulary commission is a advisory body, it's just a recommendation, and then later the Ministry of Healthcare decides by itself. Well, in our case, it leads to the following, that the positive decision is taken by the Formula Commission, but there is no decree and there is an imbalance. There's a misunderstanding why it happens. People start saying that there is no money. So why are they considering it at the Formulary Commission based of the availability of funding? Or should the Ministry of Healthcare allocate additional funding? We can take any European country. There is a classical model for assessment of health technologies. Many countries building their system using UK as a flagship and the NICE agency. Many of you know this statement that NICE representatives are saying, that NICE is only providing recommendations, but there was never the case when the Ministry of Healthcare of the United Kingdom wouldn't take it into account. And the same is true in our cases. If there is an expert conclusion, if the Formulary Commission rendered a decision, in the UK there's an expert council that makes a decision, it shouldn't be the case that the drug is not included. Either we make the threshold more stringent and tough, or we need to add additional funding. Frankly speaking, these two processes should be more balanced. Indeed, on the one hand, we need to make the decision-making more rigorous, and the same holds true for funding allocation, because if we don't let new, highly effective, innovative drugs, we won't get the desired outcome. And we shouldn't only shouldn't be insisting on inclusion. The list of the drug formulary has a long history. If we look at NICE and the United Kingdom, there is a common understanding, and many of you have probably seen a classical slide. When one technology comes in, another is leaving the chart, so to say. It's not always possible to do 100%, but there are many cases when it's doable, when it's achievable. But in our cases, the drugs are excluded only because of one reason. If they recall it from the market by the Pharmacology Surveillance Agency, if we don't exclude it, we just put heavier and heavier burden on the budget, and we don't make the room, we don't leave the space for truly innovative drugs, and we limit our patients in the options for effective therapy. I will continue taking you through the reasons. It's also a fragmented process affecting reimbursement, lengthy procedures to approve the order. It's lack of confidentiality of effective price. Let me elaborate more on that. We say oftentimes that we're short of money for drugs, and how this issue is addressed abroad is maybe by some resolution on agreement between the producer and the buyer. And the producer is ready to provide some confidential price under some conditions. This would ensure more prompt access for the patients to this drug, and also save the budget expenses. But our system, unfortunately, it's a reference pricing system. The price is determined, but there is no confidential price. Yes, we do have some instances and cases when we negotiate things with the manufacturer, and we tend to come up with a hybrid inclusion based on the condition of a volume or something else, but there is no complete confidentiality of pricing in Kazakhstan. And when it comes to innovations that have no competitors, it's also a restraining factor of accessibility, because if the state can negotiate in the presence of a reference price of $1,000 and can negotiate it for $600, this will not be a reference price, and many foreign colleagues are ready to supply these drugs. However, we need to make sure and realize why is this price confidential, because the reference pricing system is a process, and pricing itself is the process in which the state is interested by itself. Pricing is always determined by negotiation between the buyer and the seller. If the government sets up the necessary process to achieve the right price, they can do it. But it doesn't mean that the producer has to replicate it across all countries. So therefore, many countries are using this technique of a confidential price. Our foreign experts, I think, are attending a session that is running in parallel with us. So these confidential prices can be found in Turkey, in Poland, and many countries. So the official price published on average is 20–30% higher than the actual price that is delivered. In our reality, in our context, it's slightly different. Yes, it's possible to lower the price thanks to tender, but how can you lower the price via tender? It's only by competition of generics. But you won't be able to force an innovative manufacturer because he has no competitors. So we need to appeal to some cost effectiveness. What the experts have said yesterday, the threshold readiness to pay it, level of economy, and achieve the confidential price that the economy of the country, in our case of Kazakhstan, to achieve highest accessibility for the patient. Among other problem factors is also staff turnover, personnel turnover in expert organizations that are reviewing this issue. Unbalanced composition of the formulary commission. As far as I know, this is being currently addressed, because the expert presence should be reinforced. It's not only be civil servants be attending, but people with the right background. Yes, the international practice proves that Ministry of Healthcare should be present at these commissions, but there is certain quota. If its decision is made by the commission that is dominated by civil servants, civil officials, then it could be leading to some distortions and skewedness. And as we discussed yesterday, behind the doors, the involvement of the patients that should also be. I would urge some caution over here, because in order to engage them, we need to work with them, because we shouldn't take the patients as people going and rally and striking, because these are end users of any drug out there, and the opinion of patients are interesting not just because it's a trend, but it allows to achieve well-balanced interests of all stakeholders in decision making. So yeah, we need to work hard in this domain. In the future, we need to make our patients more mature for this kind of work, because we have pretty developed patient community. I see them sitting here in the audience today, and if we're going to push harder in this effort, then it should be an additional help for us to achieve a better, well-balanced market of drug. Another side is out of sync pricing and listings. Sometimes because of delays, we see this really taking too much long. Low quality of preparation of a HTA dossier. Yes, we also make these requirements. Unfortunately, this dossier, when they apply it to our institution, they're not always meeting the right quality standard. It's also hindering. Another factor to mention is later registration in Kazakhstan that also limits the access. It's fairly difficult to control, to manage it at the national level. I think it's true that large economies, US, UK, Germany, innovative drugs there, they see innovative drugs registered sooner than here. Maybe it's thanks to a proactive policy of the state that helps them achieve it, because there is such notion that is horizontal gain. If the government sees some problem in healthcare, if the government is proactively scanning the horizon, then they're able to start the negotiations, also including the potential beneficiaries of the technologies, to ensure earlier access of the patient to these drugs in our country, if it's truly necessary. I would also like to mention here patent drugs. It's not the most effective way. It's also discrepancies in form solutions, commission and orders on the Ministry of Healthcare. Reference pricing of patent and medicine. Decision making is not supported by budgeting. That's already explained by my side. And it's also lack of clear and transparent approaches to include them in the decree. Because there are a lot of gray areas when the Formulary Commission has taken the decision, and only a part of those drugs were actually ultimately included. So we have no clear criteria why necessarily these drugs were included, others were excluded, and that also leads to some opacity and non-transparency, both among producers and the consumers, across all stakeholders. And naturally, we have analyzed these factors not out of our whim, but we're wondering how to work in this direction. So I think we need to create an independent expert entity that would assess the technologies, and we're talking here about drugs as one of the most innovative segments in healthcare, ensure independence of Formulary Commission as an advisory body to take decisions, ensure systematized and standardized processes affecting access to compensation in order to ensure maximum transparency and objectivity, improving legal regulations, developing regulations and SOPs, so that every step was transparent for all actors, especially when we consider the second point. If we want to if we want to have a Formulary Commission as an independent from Ministry of Healthcare, then we need to see and have clear regulations, that's what's clear for all stakeholders. Fourth is automation of the processes for submission of applications. It's the integration with the register of drugs, nomenclature. The list of the nomenclature list is under development, but I'm sure that many things need to get an extra scrutiny, because this nomenclature list is under development since 2018. There is Kazakhstan national formulary. All of these systems, the nomenclature is related to the register, but I don't see. I wouldn't claim that it's fully operational. The formulary has no linkage to the register, and in my understanding, we need to automate and integrate all this system to make for reimbursement status. This is possible. I would like to apologize if I'm going beyond the time limit, but that's all from my side. And you see my colleagues here on the stage. Maybe they have some questions or additional comments. So I'm happy to take any questions. Is there a mic in the audience? Then can you please proceed to the stage? And unfortunately, we can't hear the question. The speaker is not using the mic. No, we can't hear you. Yeah. We understand that accessibility relates to all types of products. Everything what you showed is obvious. That's how it should be. But starting from last night, we started discussing the draft decree with all the products, with all these items that we added to the outpatient list of items. So we discredit with this the entire system. Unfortunately, we can't hear the speaker well enough.
Well, just to clarify, you said that are to be excluded. What do you mean by this? It means that from January 1st, 2024, you mean not included, but were included in this draft? They were already included. But now there is a draft where these medicines are no longer included. And probably SK Pharmacia colleagues already seen this draft list. Well, you see, this draft is not approved yet. Yes, it is a draft, but we still understand that since there is no money in the budget and the development process is, diverted. As a pharmaceutical company, we agree that old and obsolete products should leave the list to include the new products. But when we went such a long path to include that, we produce that, and now the decision is made that from May 1st, all the medicines which were initially included are no longer there. And it's not that somebody will be feeling good or bad about that. Colleagues, can you please support me with that? Well, by the way, SK Pharmacia said that they have their representative online. Ravil, can you share the Zoom link because he is watching that on YouTube? Just if you can send it to my WhatsApp. And I believe that SK should be commenting on that. SK Pharmacy, well, we received a notification last week that they cannot sign these contracts and to bring back some of the excluded positions from the previous list. Well, your microphone is not on. It's still muted. Well, now let's postpone your question. And when SK Pharmacy is here, we can get back to your question. Yes, you were raising your hand for a very long time. Colleagues, please make your questions ready. It's not actually about the study. It's we have SK Pharmacy representatives online. We have ministry attending. Let's keep all the questions to the end of this session when we have a Q&A. Janssen company, Alexander, I have a question. You mentioned about the access for the reimbursement in hospital segment, and it's also in the list of the a single distributor which is handling this issue. But there is another factor. It is it is inclusion into the other lists. Well, reimbursement will not happen even though it is in the list of the single distributor, but yet before it is included into the approved list in the order. It is. Are there any plans to unify this ministry order and the list of the single distributor? Well, let me try to answer this question. Mr. Mubarakov will join shortly for us to continue this discussion. Well, look, we actually now in our study made focus on for the inpatient care or hospital segment. The whole oncology is almost all the oncological medicines are in the list already. For the hospitals, it's a separate issue, and it's probably it's overlapping with Igor's question, not only oncology and so on and so forth. We understand that. Colleagues, you're right. It's just one study. We can, of course, analyze the whole list with hundreds of positions from the distributor list, from the approved list. Well, it takes longer. It's not only about being into oncology only. It's also about the hospital segment. And now we are covering only the. We have challenges with all the segments now and improvements needed. For the hospital segment, for the inpatient segment, it's we need actual data about the consumption levels. We have an information system at hospital level, but there is no integration. There is no centralized data collection. If we know the consumption for the outpatient, because we have the centralized data collection system, yes, there are applications or requests coming from the hospitals to SK Pharmacy. And you might ask me, like, what why can't you use this data? But actual consumption and the request might differ significantly with discrepancies. Well, we need more specific data. Well, colleagues, we discussed many organizational issues. As far as SK Pharmacy is online, let me know. Let's now go back to our agenda and we can discuss some administrative issues later when SK Pharmacy is here. Now, next in our program, we have our speaker representing CEO of the Johnson & Johnson Kazakhstan, Adalet Nazarbayev. Well, colleagues, letting me know that Vyacheslav is here. Vyacheslav, can you hear me? I can hear you. And we are together with Johnson & Johnson. Just a couple of minutes of your time. Alexander, dear colleagues, if you don't mind, I would like to share my comments. Sure, Alexander, go ahead. Well, I just want to bring your attention to the issue about the market participation of the generics and the original medicines. And it's surprising that we are a little bit not focusing any longer on the generics pricing, and for the pricing and for the pioneer drugs or original drugs. Sometimes we spend a lot of money for marketing, for clinical trials, for clinical studies, and especially if generics are of high quality, everything should be working to benefit patients, and that's how actually developed markets work, including Europe and USA. On this slide, we are showing the differences in prices, but they are significantly it's a significantly lower, at least 30%. That used to be the case, but now the practice is, for example, on the screen, it's a generic when the capsules, this is the price for generic, and actually it is almost the same as for the original drug. If we decreased it by 30%, the government would be saving about 2 billion on this procurement, and that's actually a proper way. If one generic doesn't want that, we need to invite another generic. This is another example. Some If we look at this pills, for example, it's for the saving, it will be from 500 to 800 million tenge. Regulation of the prices for generics. It might be positively impacting not only wider affordability and accessibility, because government is involved in really expensive projects. Expert council said that it's not about procuring only original drugs. Well, it's about tender because we have generic, and if the original drugs come with adequate prices, it can be procured by the government. The other part of the story is about the commercial market, where we need to regulate here as well. Today, generics, some producers are selling them at the prices higher than the original drugs, and that has a corruption. Like some schemes to thank the doctors from the pharmaceutical companies. Some generics have bigger share of the market than original drugs in terms of the monetary factor. Well, it might if we regulate that, such improprieties and might be managed, and doctors will be more trustworthy, and their integrity will be intact. Well, when the generics come, they should be drastically decreasing their prices. When international drugs come, they say, well, this is a dirty game, but there should be sanctions, if international generics come and never deliver or perform, that can be managed. If the original drug decreases price 2 times, we would like to thank this original drug profoundly. Patients will get such drugs at the prices a lot lower. But I do understand local producers. They have their 10-year contracts. They spend some money. They started producing. But when the question is about signing such contracts, it should elaborate price at max level, that it should be at least 30% less than the original drug. Then the monopoly is disrupted, and the market principles will kick in. It should be based on the competition. Why it's not about the third wheel, but why is even the second wheel is considered to be improper? Well, the plan is that the patient's rights, in terms of many studies, in terms of the many therapeutical practices, will be expanded. But now we need to look at the medicines, especially with since we are looking at the reference countries where such practice is in operation, it's in functional. It is a good tone. When you're just producing a generic, you're not spending huge budgets for marketing, for research, for trials. Well, it's probably not that easy, but this practice works. If we go to Korea, first generic, it will be minus 30%, second will be another 10% less, and we have tens of generics with prices very high. Even with an open market, there should be some regulation, quality control, therapeutical equivalence, bioequivalence should be controlled. There are cases when the first delivery is fine, the second delivery is done, and the quality is not really that good. Independently, whether it's original drug or a generic, they should have equal therapeutic equivalence. It's one of the good tools for the Ministry of Healthcare to optimize the budget, to buy more this is a problem with Vyacheslav, right? He is frozen. Vyacheslav, can you hear me? I can hear you well now. There were some disruptions with internet from your side. Can you please repeat the last 30 seconds of your speech? Well, sure. The practice of regulating prices for generics after they are available on the market after the original drug, it's a common practice. And even in Korea, the first generic is minus 30%, the second minus another minus 20%. That is a proper, like reference for the patients in the drugstores, and is about this is about the substances, and to sell generics with a 2% difference, it's a nonsense for me. Or even if it's sold at the same price, if we replaced original drug to generic, and no, it's only 1 cent cheaper. That's not the way it is supposed to be. And this is about the tariffs. It's about measuring everything from one drop and up to the working hours of the doctors and nurses. Well, if we are selling generic prices at the same price with original drugs, we should be more concerned about that. Thank you, Vyacheslav. I agree with you totally. I actually second your opinion. Well, but it's also about negotiations. Nobody uses 20%, 50%. In some countries, the second medicine to come to the market is 50% less. That's a normal practice. At the same time, it's also about supporting local producers. It is about ensuring that nobody is impacted. Patients should be having the same quality. Manufacturers should not be bankrupted, but it is the common practice that the generics price are lower than the original drugs price. Thank you for logging. Thank you for joining online. Well, we have the head of the department, Mr. Ulugbek. It's very important for the ministry to understand this process, not only for the inpatient or outpatient only. It's also about the commercial segment. I know companies which just copy the drug, but then it's even more expensive than the Pfizer's original drug. It is really not as it is supposed to be happening. Thank you very much, Vyacheslav. And we have Nihat, who is online. Can you turn Mr. Iskaliv's microphone? Can you hear me? Yes, we can hear you, but we cannot see you. Well, thank you very much. Well, I did not hear the first question, but for the second question, what Mr. Alexander mentioned, my position is a balanced one. I agree that I agree that we should remember that we have the regulation and the article which was on the screen previously. We looking now at all the different arguments, at the general experience for the insulin procurement when Novo Nordisk with Chinese insulin were competing. Well, actually, our position is that the global practice, it's important. We support the idea that such price regulation is needed, where initially there is original drug, and it is original. And people know my position in terms of the organization of the original drugs as well. We are always in disputes about that, but as a person with experience in investment, I do understand that when the best and the first comes into the country in terms of innovation, but it's also about balancing it to support local producers as well, where the import is. And where the local producers are, we should be getting back to this provision and to ensure that it's functioning. We have working groups following our suggestions.
And with regards to domestic manufacturers, most likely the interest rate will be a different size. It will not be 40, maybe 20. There is a group that is now doing all the calculations. So my position is in favor of this article. SK Pharmacy has raised this issue, and there is a major reform on HTA2024KZ. We have an MOU, and we're working hard to ensure localization and full cycle. So my stance is that I asked a question yesterday. My experiences in oil and gas and logistics, and there are state standards and everything, because we are playing in a global world, and in order to compete, to sell, to create pharmaceutical hubs, we need to observe the standards and move gradually towards it, like the heme farm is moving in this direction, and maybe smaller companies which will, but there are some hindrances for experts. So HTA2024KZ will definitely see a major reform, and the SK Pharmacy played not least important role in this. And the third point, if you could remind me, because I connected a bit late. Igor, if you are here, maybe you can repeat your questions, and please use the mic. Good morning. The question was about the new draft 75th decree. We've added what we wanted. You added, you purchased we received a notification later that you are returning the product to us because there will be no pay. However, looking at the regulations, we realized that the government has no right to terminate the contract. Could you please explain? We understand that you are a victim in this case. You're not at fault, but so the decision was made by the Ministry of Healthcare. The issue is now under consideration. What we have purchased maybe will be retained. What hasn't been purchased, and in that list, most likely will not be purchased in the nearest run. Maybe it will be carried over to the next year. As you know, we're not allocating the money. We're just an operator, and we are following the orders of the ministry and the regulations. So everything was we will do everything according to the law. We are always in favor of smooth and gradual work because it's a matter of business. And we understand that these are also your losses. We're trying to stand our ground, but there are a lot of nuances related to the law and everything what we can do. Return it. We'll try to make it smooth. If possible, we'll try to defend this funding. As a person who has been working in this field, it's still unclear to me how 90 items that haven't been purchased are still remaining on the list, how new items, high-tech items, emerge, and at the same time the old one remain there. So we need to scan and clean the list. So I just heard the end of the discussion while the domestic manufacturers. So my personal stance, we are producing very cheap generics that are not competitive. And our manufacturers are bearing social responsibility. But I think we committed a systemic mistake. The government, represented by the Ministry of Healthcare, should have done a forecast. What would they need in the next 10, 15 years produced locally to lower costs? That was never done. They would sign a contract to what the domestic manufacturers could produce. And now we end up in a situation when the companies are ready to purchase, and the Ministry of Healthcare, by applying different instruments, thinks this is not relevant, this is unnecessary. It's all certainly relevant because the technologies are moving ahead and there is not endless budget. That's why we raised the topic of a forecast 3 years ago. We raised the issue of our own needs that we can emphasize in case of local production or full cycle. So therefore, as the chairman of the board, it seems like if there was a stable forecast, it would have been way different. The companies would have invested where the demand was. It should have been supported by some evidence data. Well, it looked like they turned to us, we signed the contract, and only then we start asking whether you need it. As an investment person, I think it's incorrect. This should have been done in advance. Dear Yerhat, it's great that you're with us. Thank you for joining. I don't know if you heard my presentation. I also echoed your words. Our list should not be just a garbage. With all sorts of trash. It should be both investment and divestment. So some technologies that cease to be relevant, they should be dropped out of the list, and we shouldn't spread ourselves too thin. a lot of issues about biology, and indeed in international context, biological drugs are not purchased. Um, because it's a separate group of drugs um, for this international proprietary name, because generic and biosimilar are two different stories, and we will have a next session on that. After this session, there will be a short session on biosimilars and international best practices. And we need to be aware of planning. I know you've been raising it repetitively. In order to plan properly, we need to have actual data on consumption, because these calculations, modeling, and so on, they're very approximate. The best planning methodologies are built on actual consumption for the past year. Just like you said, we need to see the consumption, and yeah, the requests and the real consumption are not the same. Yes, totally agree. I'm the person who raised the integration issue with the minister 3 years ago when the labeling was coming out. Now we are 5 months into this process. Yeah. What are these data about? Is the historical data of consumption from different hospitals. So I'm supportive of diversified accounting of consumption. While Ministry of Labor is capable of doing that, the Ministry of Healthcare not. Yes, exactly. There should be in the medical record should capture all that. Yeah, that's what we are requesting, to make more specific. And this is the position of the Ministry of Finance. They see that it's done partially. There's individual accounting, and they want to see it. Yeah, we are ready on our side to go for it in terms of logistics. And yeah, we just need the input data. We had a new vice minister meeting yesterday, so yeah, but the best way forward is to have everything smart. I understand that business and big farm and local manufacturers, while big companies are leaving our market, we are also triggering an alarm, writing huge letters, because they weren't heard, they weren't seen sometimes. I'm wondering why there is only one vaccine big farm present, why are others leaving, why not competing with each other. So we're working closely to trying to bring them back, to give a rationale for that, to ensure competition. I think it needs extra localization, and what we are promoting is high quality. They left the market, and nobody started asking why. Is it because of regulation? Maybe they took some global decisions on. There are some companies that left the market, and they hid behind the regional distributor, and now we're all standing in a long queue. Some have left completely without any substitute. So yes, dear Yerhat, indeed, we are debating this actively. The issue of planning is absolutely relevant. We have the representative of the National Medical Insurance Fund, head of the Department for Medical Pharmaceutical Provision. So over to you. Good morning. So as of today, the outpatient pharmaceutical provision has almost doubled from 87 billion to 230 for 2024. The amount is not fixed yet, but tentatively it's around 214 billion. So there is an additional amount of 36 billion. But anyway, this amount is not meeting the needs. We all know that there is a lack of the limits are not allowing us to satisfy the demand, and the demand is stipulated by the Ministry of Healthcare, and the fund is only giving its concurrence and approval. But again, no matter how well we approve, the quality of the demand formulation is not changing. So we need to decentralize it and give it away to the Department of Healthcare, so that the local healthcare departments could plan it better. And why all this turbulence occurring around this 75th order? Because the amount was overstated to 250 billion, and that resulted in the ministry revising it because they thought the amount was inflated. Now its list is being updated for the outpatient support. Some drugs are revised, some added, new drugs were suspended for purchase and put on hold. I hope that in the week to come it's going to be all resolved. Yeah, well, the demand needs to be carefully researched and studied. There should be a thorough analysis preceding all that. There is a working group established that is revising the demand forecast, the demand estimate. So, and as a result, we should see a new limit for an additional demand. Thank you. Well, I think this statement resonates well with the need to refine the methodology of forecasting and planning that you could have heard in my presentation, and the speakers who have joined us also echoed and cited us. I think that everyone who came here see that the Ministry of Healthcare realizes the need to change the planning that determine the demand numbers, and it's also relevant for the Ministry of Finance. I would like to remind you that our list is not an bottomless bag. It should be a clear process for investment, divestment, and it's all driven by innovation and our real needs. Now I would like to give the floor over to Diana Lachinova, head of the Department for Market Access and Research of Economy, Results of Healthcare from Johnson & Johnson for emerging markets. And yeah, over to you. Good morning, dear colleagues. Let me start my presentation with a small quiz. Why does it matter to always be aware of and remember about innovations? Even such audience like us, some have 2 degrees, some did postdoc, PhD, and we don't always remember about the value, the true value of innovation. And I'm going to illustrate it with a pretty straightforward example. It's a small quiz. What is there in common between all these people? This is Freddie Mercury, or Isaac Asimov, and American supermodel. Unfortunately, they all died because of the terminal stage of HIV. Now all these people of this kind, had they been receiving innovative therapy, they could have lived just the usual life like other population. Introduction of beta blockades, inhibitors of IPF, reduces the risk of cardiovascular outcomes by 30 and 40%. Now, the issue of vaccination that prevents from 45 million deaths a year is well proven. So Johnson & Johnson is not producing influenza vaccine. So it's just an experiment, intellectual experiment. How many of you do influenza vaccination? There is an evidence base there. It's pharmaceutically proven, but how many of us are really doing this? B, hepatitis is virtually easily treated disease. It's a fixed protocol, and the person gets rid of disease. We always look at innovative drugs, and they add a certain number of years of life. But over the past years, the well, the patients now live 20 years longer with the plasma cell myeloma. The drugs help reduce costs, direct and indirect, including for hospitalization if it's an outpatient. And a large meta-analysis have proven that hospitalization costs are drastically declining for cardiovascular diseases. And we remember when we had patients with cardiovascular diseases for preventive purposes in hospitals, but it's all gone, nearly gone now. Or at least it's very, very rare. Innovative biological engineered drugs allowed to return back to work those who have arthritis and stay longer at work. In other words, to bring money to the state in form of taxes, not to be hospitalized, not to get sick leave, access or delayed access to a drug also affects the community and how many years a person could have lived. We have analyzed access to abiraterone and how the delayed registration influences between FDA between registration and access or reimbursement. It's around 25,000 years of life in total is how many years our patients lose. It's with prostate cancer and another 5,000 years. This is published data by European countries. As for the region where I operate, this is the data of the Association of Manufacturers and Middle East and Asian countries and Africa. Naturally,
Let me show it to you. This is United Arab Emirates and Saudi Arabia, rich countries, and countries which are poorer. But this is the country with it's a country with GDP 4 times less than Kazakhstan per capita, and lately they are quite actively promoting in terms of the innovation access and are introducing universal insurances for medicine provision. And Algeria, after they exhausted their oil resources and innovations were in the gap. Nothing was on the market with innovations, brought some catastrophic results in medicine and healthcare. Now, step by step, they are getting back to inclusion of innovation, to allocating financing. As of today, many cancer drugs are included. A country, even with a very small budget, should understand that innovations are drivers not only of cost but also of development of the other, as Professor Garrison said, externality. And this slide was also showed by Professor Garrison already, and Alexander Vladimirovich also quoted that, well, now we have local data at last, and I think that next study will be quoting Kaspor study, and we will see some other more optimistic results for Kazakhstan, and including the FPI. We together jointly with IQVIA analyze that what can be the key reasons for delayed or restricted access. Delays with registration, what we discussed quite extensively here, HTA, how it is happening, the policy and implementation, procedures, stuff, and so on for HTA, pricing. And price setting was mentioned on multiple occasions, and reimbursement schemes. And overall, what is the basis of economics? That the systems and the resources in healthcare are restricted or limited. What are the options? What can be solution here? Well, once again, we discussed all of these aspects already. This is revisiting policies in a timely manner, collaboration as the industry, as representative of pharmaceutical sector. We are always open to dialogue. You have 1 minute left. Sure, I'm almost done. And this is the proper diagnostics as HTA price setting again. But the position of Johnson & Johnson, it's like yin and yang. We are ready to bring innovations to the market. We are ready to increase to build their capacity. We are ready to deliver medicines to the patients. We are ready at the same time to introduce innovations, to have the patient support programs. And thank you very much for all of that. Thank you, Diana. Well, next, I would like to provide the floor to the CEO Kazakhstan, Adalet Nazarbayev. Adalet, floor is yours. Well, thank you again. Good morning, dear colleagues, dear participants. Well, in this panel session, we raised different issues, including the ways to optimize the budget, how to guarantee access to innovations. And Vyacheslav mentioned already that generics play an important role. I would like to go to a higher level overall about the financing of the healthcare system. I would like to bring several cases to compare Kazakhstan with, and what can cause the underinvestment of the financial system. Well, here on this slide, we have a comparison with the countries from our reference basket in terms of the price setting. These are countries which can be compared to Kazakhstan in terms of demographics or macroeconomic aspects. We see the percentage from GDP from the state budget allocated to the healthcare. 2.8% is a lot less than in other countries we are comparing ourselves to. The percent allocated to the healthcare from the state budget, from the whole government budget, Kazakhstan allocates 8.3% to the healthcare. And this is, again, a lot less if we compare with other countries. If we look at the figures in absolute figures, well, we have two diagrams here. First, per capita costs in healthcare overall in USD, and on the right, it is a per capita cost to ensure access to medication, again in the United States dollars, and the gap is even bigger than in the countries with reference from the reference basket. We can try to save the budget time and again trying to find solutions, but without radical decisions to increase the financing, we will be facing challenges again with the shortage of budgets and investments. Diana was also previous speaker. If you attended her speech yesterday, there was statistics for the orphan diseases, and the budget allocated in Russia for the orphan for the organ diseases. Again, it's just to understand what the situation is like in terms of the amount. Alexandra mentioned about the physical access today to the medicines, how they reach the patients. Well, we have really very time-consuming procedures for drugs to reach the patients. Like when the need is occurring and before the patients have access, it's about 6 months, while the physical access of the patients to the drugs might not be actually ensured, and that is like it can bring hospitalization, and the hospitalization costs a lot more than the outpatient care, and also adherence issues are one part of this discussion. There was one application sent to the patients who are already in therapy, but it was cut because there was no funding. And the justification was that the medical organizations will be able to send additional requests in 2024. All the needs were put together, but again, it was never approved because financing is not there. It's a challenging situation in the country, but the patients, they are our citizens, and the patients who are already in this therapy, and the accumulated needs with the cuts will be left without therapy sometime this year. Well, another example I would like to show you. Well, basically today Alexandra also mentioned that the Formulary Commission looked at some of the medicines, and probably some of the reverse process will kick in. But as a company, we would like to ask for more cautious, more substantiated approach, because some of the drugs might be included into the list. They are already procured at the level of the outpatient, and for the hospital segment to include that will be delivering some savings, because like outpatient care is a lot less expensive. There are also drugs included into the outpatient care list of drugs. Patients are have access to that, and inclusion of the of another medicine will not be increasing the number of patients. It's about ensuring wider choice for therapeutic purposes for patients. And also from the perspective of medicines, they might be included into the insurance scheme reimbursement that might be motivating people to be part of this scheme, and it will have additional contributions. It's about reallocation of costs that's successfully implemented already, and we are ready to expand our cooperation. Thank you very much for your attention. That's all I had. I tried to be very brief. Yes, well, very deep analysis of the existing situation, and I believe it is it's kind of a summary in your presentation of the ongoing discussion for the planning of procurement and so on and so forth. Well, thank you very much for your support, but I believe that all the government organizations, and today in our session we have Director of the Department of Organization of Medical Assistance, Mr. Adilbekov. Well, can you also comment on the topic discussed today, what your opinion is? Well, good afternoon. Oh, well, no, good morning still. Thank you very much. I would like to thank organizers, first of all, for invitation, for participation in different meetings. It's a very good thing that we have such platforms where we can discuss such issues to bring improvements, and to have such platforms for discussion is always appreciated. Yesterday in plenary session we discussed more the role of the HTA and the future impact of HTA for the further development of healthcare system in Kazakhstan. But today we have more specific issues. It is about provision of the medicines on the outpatient level, also for the hospital segment, with the Kazakhstani formulary. It's a very interesting platform for such in-depth discussions. As of today, the Ministry of Healthcare of the Republic of Kazakhstan is prioritizing these issues. We are really focusing on them. Well, as an ex-member of the Quality Council, I also participated in the discussion of different issues and the HTA processes. And actually, the HTA is changing with time. If initially we were mostly discussing high-tech medical services and technology related to medical equipment mostly, and the opportunities, possibilities for high-tech and technological medical services delivery. Now, with the clinical protocols and with the specific technology discussions, more attention is currently paid to the issues related to clinical and pharmaceutical economy aspects of the medicines, and a big role is played by so-called readiness threshold to buy, compared to the from the perspective of cost-benefit analysis. It's one of the most important tools for the decision making, because healthcare technology are improving on an annual basis. Colleagues from United States yesterday, for example, mentioned that it's about 46 new medicines coming into the market on an annual basis, and just one country. A lot of technologies are evolving globally, and it's very important to take proper decisions on prioritizing and also on application of this technology locally in our context. Well, HTA is an irreplaceable way and to discuss and to consider in this light, but yet we have to follow the principles coming from our regulations. And as you probably know, today in Kazakhstan we have rules for the HTA, and within these rules and procedures, a committee and the expert councils to run the expertise of this technology. It's about ensuring transparency and efficiency. It's also about having assessment review on how much these technologies presented today and existing technology meet the real needs of patients and medical organizations. Well, I would like to comment on Alexander's presentation just to clarify. HTA is not under the Ministry of Healthcare. It's not a direct decision of the Ministry of Healthcare. It's Quality Council, including representatives of association, of civil society, representatives of leading leading medical organizations, experts. Therefore, at this council or committee, it is a multifaceted body, and initiators for the HTA can be not only the authorized government bodies, namely Ministry of Healthcare, but it can be initiated by the associations, by producers and suppliers of these technologies, and also the medical organizations, academia, and research institutions. These issues which are raised are very relevant. Improvements are needed even for the outpatient list of procured or approved medicines. It's about all the stakeholders' participation in the discussions, including the pharmaceutical companies who will be running further improvements. I hope with your support, and I hope it will be a joint effort. Thank you very much. Thank you very much. And about the next session for the lists, this is closely associated with the previous session. Can moderators and speakers proceed to the stage, and we will be starting our next session.
Так, дорогие коллеги, не уходите, пожалуйста.
Well, I have an appeal to make. Don't go away. We will start immediately because we already lost 8 minutes. Unfortunately, the previous session got extended. It was truly interesting, and I would like to give the floor to Shingiz Chingaze. It's about the approaches to include biosimilars for the potential reimbursement. Don't worry, we're not going to wait anyone. We already lost 8 minutes. So those who are interested will stay. Most precious thing in this life is time. Let's excuse everyone who needs to leave. Let's proceed with the presentation. I would like to take you through the approaches and criteria to the biosimilars assessment for the inclusion to the state list of reimbursement. As you know, bioanalogs or biosimilars are not the same as generics. These are biological drugs that is similar to the original, but is different in terms of production and the strains of living cells that we use and the nutritional environment. So we cannot call it equal to generics. The flagships in the field of in this field is European Medicine Agency and FDA. Well, we have in our country the rules for registration regulated by Eurasian Economic Union. Let's come back to the policy of cost reimbursement. Different countries have different rules. There was a study made in this field to find the best policy. On the basis of the research findings, I would like to explain you how it works in those countries. Reimbursement of costs for bioanalogs is regulated in most countries of EU. That shows its importance to penetrate the healthcare in all countries, including EU, Iceland, Norway, Russia, Turkey, Serbia. The responsibility for cost reimbursement rests with the national authorities, as well as the regional budgets can also be deployed. In the majority of countries, it's compensated across all indicators, just like for the original drugs, irrespective of the indicators received during the first clinical trials as part of the registration. Two-thirds of European countries have internal policy of reference pricing to reimburse the costs for this group of drugs. This policy can lead to establish the pricing policy for biosimilars and originals on the same level like it's done in Bulgaria, where the medical workers are suggesting to the users who are receiving therapy to apply biosimilars. And those countries where there is a link to generics applied, they can establish the biosimilar prices in a similar fashion. Like that for generics. And now let's take country by country. In England, bioanalogs can also be included into HTA assessment for NICE, while for others, such as Scotland's Sweden, they compare biosimilars and original drugs. This is the main analysis for cost minimization. In Germany, biosimilars are not included in HTA, only price comparison. Why do we actually need to do economic assessment? If it's a reference drug that's already been paid, it's a standard, and the bioanalog with same indication claims for compensation, we need to do economic assessment when there is sufficient similarity between them. The argument were offered in different works, such as Stewart and his colleagues suggested to use equivalent as a therapeutic equivalent. If there is sufficient assessment that would justify compensation of, we need to compare biosimilar and the original drug. Currently, such practice is used in a number of countries and most likely will be applied for the majority of cases when the bioanalog requires compensation. Ideally, they use clean price to properly assess, because the prices vary depending on the region, city. That's why they compare the main prices of the registered drug. It's recommended to use the periodic and localized data within the country. We can claim that the efforts for this assessment, they hinder and delay the access of the market, of the drug to the market. Well, some basic comparison is sufficient for further reimbursement. Sorry for going too quick. If the reference drug is not used in the country, if there's no reimbursement, then we need to do full economic assessment of the drug and its therapeutic equivalence. This can also be vital to assess placebo effect. When the patient knows that they are going to take biosimilar, there could be some negative bias, less response, less commitment to the drug. and to the therapy. And at the end, I can tell you that EMA has approved 54 analogs, FDA 26 analogs. The potential for bioanalogs is obvious. With lower costs, it ensures wider access for the patients to these drugs. Right, so thank you very much. We have some time for the debate, but I would like to give the floor to the head of Kazakh cluster, Natalia Garipova from Stada. Yes, I'm excited to welcome everyone who decided to stay with us. Without further ado, would like to leave more time for Q&A, for discussion, because we lagging behind the schedule. I'm responsible for business Stada in Kazakhstan, Tajikistan, Mongolia. In a nutshell, Stada is taking care, as part of its mission, of the population's health by establishing effective partnership relations, including with the customers and users. And Stada chose three main areas of operation. First and foremost, it's CHC. It's drugs not requiring prescription, where we fill our leadership position. Second is generic, and third is specialized therapies. Biosimilars, it's a novelty for Stada. The drugs used to treat oncology, eye problems, systemic diseases, central neural system disease treatment. Speaking of biosimilars, without delving too much into details, biosimilars, just like generics, offering to enhance the coverage of population and give more patients wider access to get this treatment, this therapy. And despite Vyacheslav just debating that, despite the level of cost for biosimilars, it's not as easy as it sounds. Like, you reproduce it, and why would one incur this cost? Despite high level of cost for production, quality assurance, compliance with all pharmaceutical practices, indeed, we as a company realize that biosimilar as an outcome will be 25–30% cheaper than the original molecule. Since the majority of bioanalogs are covered by the government, then on top of the economy that we've been repeating so frequently today, it's the expansion of access to a wider group of population to the therapy. And that's probably our ultimate goal. Speaking of Kazakhstan, this is our primary focus. Speaking of Stada overall, there's Sweden, Romania that have successfully introduced bioanalogs to the market, and certain practices have been improved in healthcare. Therefore, and they gave a chance to healthcare system to focus on a bunch of other problems by saving their costs and by broadening the coverage. On behalf of Stada, I can tell you we have one common goal, who is the end user. So on top of savings, we would offer a wider group of users high quality therapy. Okay, let's hear some questions. I don't want to steal the thunder, because Dr. has explained the details, how it works in Europe, how EMA, how FDA has recognized them, and many companies that are producing biosimilars trying to register such drugs. And I remember that since 2005 there was a thought that biosimilars are 30% cheaper than the original biological drugs, and the technology is growing. In 20 years, new technologies will arrive again. So let's start with the participants. Dear Talgat, thank you very much. I would like to thank the speakers and the participants. I have a question for Talgat and Natalia. Did we get this right that Stada already has biological biosimilars that already registered in Kazakhstan or in the world? That's my first question. And the second, for Talgat, there is a notion of biomimic, biologically incompatible drugs. When we question if it's biosimilar is registered in a strong regulatory country like FDA, for some reason, not all biosimilars can be registered in these countries, but they can be registered with weaker, with more loose. Let me start with the end, and then Natalia will respond. Speaking of regulatory environment, we're now part of the Eurasian Economic Union, and we used to have pharmacopoeia. Ardak would always say it all comes down to pharmacopoeia. If pharmacopoeia is rigid and they have rigorous requirements, then it's not possible to register a mediocre, a low quality drug. But so pharmacopoeia of Russia and Kazakhstan and Belarus is recognized, but it's not the case for other countries. However, I still haven't seen biosimilars in Kazakhstan that weren't registered by EMA or FDA. So biosimilars are either registered in the EU or I can even tell you that there are some Korean biosimilars that are registered in Korea, and the Japanese regulatory body is even more stringent that FDA and EMA. Since 2002, they completely switched to an individual approach for registration of a drug. We know that China is not lagging behind and is also pretty tough. They also headliners. However, they recognize if there is an EMA or FDA is registered, the first two models can be accepted. This 2,000-year-old hieroglyph Chinese alphabet has lost the game over here. So we need to consider it from the standpoint of quality. If there is a well-grounded complaint about the ineffectiveness of the drug, if people are talking about local production of biosimilars, then the doctors' community needs to play a more active role. I would quickly respond to the first part of the question. There are 5 molecules that are registered in EU. Speaking about Kazakhstan and Central Asia, then we're now in the process of registration of 2 molecules. One is going to be brought to the market in 2025 and another in 26. We ran out of time. Everyone is waiting. That's why let's see if you have any further questions. I'm just eager to stick to time. I value everyone's time. Coffee is waiting. Let's see if you have any more questions. So I think it was clear for everyone the stance of many former companies is clear, as well as ours. We're always in favor of biosimilars coming out because it lowers the price by 30% for the original down to biosimilars. So why don't we practice the same approach to the original drugs? This is frequently discussed. I approached our MPs 2 or 3 times about the original synthetic drugs that are present on the market. However, the domestic manufacturers double the price than that of the original. So, yeah, I can openly discuss it the price will be my head. It's just a matter of corruption, nothing else but that. Thank you very much, and we're done.
Идет? Раз, два, три. Раз, два, три. Нет. Один, два, три. Один, два, три. Один, два, три. Сейчас, но все равно есть эхо.
Раз. Не мог.
Раз, два, три. Открой фикс. Открой, что было открыто здесь. Раз, два, да? Один, два, три. Вот сейчас нету этого.
Вот, смотри, я нажимаю.
Вот сейчас есть.
Из этого.
Да.
Нету никаких.
Вот сейчас, знаешь, как будто с задержкой. Вот так.
Раз, раз, два, три. Раз, два, три. Раз, два, три. Раз, два, три. Раз, раз, раз. Раз, два, три. Раз, два, три. Раз, раз, два, три.
До этого он был как будто холл такой прям.
Был холл, потому что этот микрофон, я сейчас его из мастера убрал, и те микрофоны ловили его просто из зала. Это, и, конечно, эффект холл, потому что здесь холл.
Вот
Надо
этот с
было...
мастера убрал, получается.
Ну, сейчас его, видишь, нету в мастере. Я его сейчас отдаю только в ЦЦУху и там в мониторы. И те микрофоны все выключены. Как мне надо?
Ну, мониторную линию.
ЦЦУ. ЦЦУ. ЦЦУшка. Раз, два, три. Вот. ЦЦУшка, вот. Они... Они... Раз, два, три. Нет, лампочки. Они здесь не должны быть. Это идет конкретно вот канал. Пришел, ушел. Я просто не знаю, нахуя я это сделал. Можно было просто тебе их отдать и все.
Да.
Уважаемые участники,
Dear participants, while we are trying to gather here, can you please come closer to the stage? Please take the front rows. It makes no sense to use the rows at the end. Just because we are broadcasting on YouTube, it looks better with. Especially for those who are on the left, can you please come closer to the stage, because that will improve our picture in YouTube. Go to the front rows as much as possible. Well, everybody is ready. I hope you are all set. Can you please show the video and promo video after the background picture is set? Once again, let's thank all our speakers for their participation. And today our speaker is Govench Kuchkai, partner for convex research at EDTP University, professor in Turkey. Please welcome our professor. My name is Aliman Madieva. We are the host of this conference from 2022. This is our second big conference. This year we've invited more than 10 speakers, foreign experts who are participating in person and online. We also have people who are joining us from abroad. Unfortunately, not all of them were able to come and be here in person, but hopefully it will be one of the biggest conferences in Kazakhstan on HTA-related issues. Probably it might be HTA Central Asia. And for all the participants who were attending yesterday and are attending today and who are actively helping us to promote these ideas, for you to be also our followers, our supporters, and not only to mention us in your Facebook posts, but also in all practice and work-related issues as well. Well, today it's our second and last educational symposium, and we will be finalizing by 10 minutes 1 p.m. and it's about expanding access to expensive medicines. I will be covering the situation about the allocation of cost to the expensive medicines in Kazakhstan. Will you please project my presentation? Next slide, please. Yes, well, when I will say next slide, just keep switching the slides. Here, very briefly, macroeconomic indicators of Kazakhstan, as it was mentioned earlier. Our country overall is one of the leading in Central Asia in some economic indicators in particular, and in terms of the health of population, we are also trying to do our best for some indicators, decreasing the maternal and infant deaths, one of the leading parameters in the World Health Organization's parameters and indicators. But yet, despite the efforts that we are trying as an emerging market to be within the 30 most developed or 50 most developed countries, of the world, it's still a long pathway. We have a lot to do, and in the healthcare assessment by induction method would be helping us to improve not only microeconomic situations we have presently, but also for macroeconomics as well. Next slide, please. The problems in healthcare are universal, I would say. As Tolstoy said, every happy family, all the happy families are happily almost the same. All the family not in peace and happiness are struggling on their own. Well, since we are also researchers, and we are trying to generalize more. And in some aspects, we are trying to have an inclusive approach to resolving issues in healthcare. Overall, Kazakhstan is not really different from many countries of the globe. We have the same problem with aging. We have higher priced drugs, access to this medicine, drugs, and pharmaceutical products. In parallel, epidemiological indicators are also increasing the burden of chronic disease, but it's a global trend. Social and economic pressure is also increasing. We will not be referring to this problem, but that's what we feel, that there are some changes in one part of the planet, and that is impacting the other part of the planet. What's happening in one country is not just a problem of that country with globalization. It is impacting other countries as well. Budget restrictions we are always having. But the problem is, and I also mentioned it yesterday, not everybody was there, unfortunately, during the last session yesterday, but there was such an interesting discussion that when many countries are introducing their countries, representatives of countries are saying, we are a small country, we are just 4 million, 20 million or something like that. But let's look at some other countries. Scotland, for example, only 5.4 million in 2023. Denmark, and Scandinavian countries, the population, the demographic density is not very high there. But in these countries, they are trying their best to increase the efficiency of their resources. While we have $2, just for the sake of example, $2 can be spent very efficiently for useful things, but other people might not be spending wisely. That might be the problem. Why can't we bring the country to the specific family or to the specific person who is financially literate? And looking at the HTA is a financial literacy, actually, which is needed at the level of the societal, political level. And when we are good with counting our money, with our estimates in prioritizing where the resources should be allocated, and the value-based healthcare, the model we were discussing back in 2022, then it might bring some change. If we are looking at such countries, Singapore, young Asian tigers and dragons, how they started, why their industry is developing in one direction, how they did that, how did they manage, probably we need to revise and reconsider some of their approaches to allocation of resources. And The next slide, please. Financing of healthcare. Well, once again, to bring your attention that the average spending for healthcare, if to compare with OECD countries as a reference, it's about 3.7%. Well, just to reiterate, Luke Garrison, a very honorable professor and my teacher, today he was also delivering great lecture on the value and economic approaches. He said that when you look in percentages, this very often the share will not be telling the story. What is happening inside the costs spent in different areas. And when we just look at the shares that might look huge. Okay, not 3.7, but 25% from GDP spent for healthcare. But it's internal macroeconomic calculations and estimates. But just to let you know, I hope that at least you will be aware here locally that when we bring that from absolute figures into some percentages, the perception of people of the shares, statistic calculations, persons, very often they are not considered. They are not catching attention. A big figure is taken out of the context, statistics is not being elaborated, and there is some discrepancy or misunderstanding at the level of the policy making, out-of-pocket costs. Let's have a look from 2018. That's 2020 decrease from 33% out-of-pocket expense up to 37.7%, and in 2022 it is also flattening at the level of 2020. Well, looking at the assignment of the head of state in the bottom left, well, it's indicated that the healthcare allocation should be brought up to 25% of GDP. It would be great to improve the social disparity and social social feelings might be improved. But, well, how are we going to bring that to this 9%? By investing huge amounts, lumps of money into this bottle with which is not intact. It has some it has a hole at the bottom. We should be looking from the value-based healthcare. From that perspective only, when we have this hole fixed, bottle intact, then we will see that the companies and industries are ready to start negotiations with the customers. That might be as a government or representative or from quasi-public sector patients. But when at this level we have good quality negotiations, only then, again, this is my personal opinion, we can bring this to such a good indicator as to 9% of GDP. Next slide, please. This is a pharmaceutical market of Kazakhstan. What is the consumption rate? What's consumed in Kazakhstani tenge local currency, and what's the consumption in USD, US dollars? Again, this is a specificity of Kazakhstani economy that we are trying to de-dollarize our economy. And when we run calculations in tenge, we have one indicators from absolute figures. When it is being transferred into reference or comparative values. Well, when it is in USD, it's not such a huge amount. Next, this is the diagram of the drug supply scheme in Kazakhstan. This is a scheme approved by the Ministry of Healthcare that is that's coming from open source. It's not. It does not have any subjective reasoning here, but look at quite a developed network. This is a system, quite a sustainable system with such players as producers, then the nut cells, registrator of the medicines. From nut cells, regulations go to the Ministry of Healthcare, which already after the drug is registered, it sends it to the National Healthcare Development Institute, and their HTA-like appraisal is happening there. Well, it's HTA, but I would not be calling it a full-fledged HTA, but therefore I'm calling it HTA-like procedure. And then after the professional expertise of this medicines is fulfilled, then the national board will be including or not this drug into the national list. Then SK Pharmacy is another player which procures for medicines, and SK Pharmacy will be running procurement of the medicines in line with their internal and national legislations and regulations, and they are allocating it to the hospitals. From hospitals, these medicines are distributed to patients. Well, it's not a small chain for agents between the producer and the patient. It is an indication that government is interested to have high quality, higher accessibility and affordability system to the patients. Again, this is this scheme was also contributed with the CASPOR Association, and all these aspects definitely need to be considered further. It's somehow a network, it's a conglomeration, but it's like a puzzle quest. They might be changing, they might be supplemented, but at least for these structures not to be over-regulated. When there are too many players, it's a bad thing. But when there are just a few, it's also not good. We need to go to find a golden compromise here. A golden middle. It is possible with the attraction of many scientists, consultants, international experts, and consultants to be participating in such strategic developments and evolutions, then it will guarantee somehow high quality result. Next slide, please. Price setting and reimbursement in Kazakhstan, how it's happening. Overall, again, it is information coming from the open source. It's publicly available. Up to now, the price setting was under the specific structure in the National Center of Expertise and Medicine Regulations. First, it's registration of the price with the marginal price registered and market price. Then it is about the threshold price, maximum price for the insurance scheme for reimbursement. And the decision is made that this drug will be sold or procured at this price. And then it is about the list of reimbursement for the procurement within the guaranteed volume of the free of charge medical assistance. It looks like it is transparent and clear, but again, devil sits in the details. We need additional studies for the procedures which are happening in between these 5 elements of the system. For the price setting and reimbursement, there might be some lags, some gaps where there is a human factor or regulations are not very clear or might be ambiguous. Such things impact the accessibility of the drugs and bringing them to the patients. Next slide, please. The provision levels in Kazakhstan. The system is no different from international systems. It's quite similar. There are outpatient drug supply with a specific list of medicines at the level of the primary health care. Patients can look at the single distributor list. It's about 140 diseases, 334 drugs and medical devices. SK Pharmacy being the single distributor, they procure and they ensure that all the prescriptions are fulfilled. It is about the hospital segment of it. as we call it. There is such a split. 70% is being reimbursed from the national procurement, and 30% are procured autonomously. In this situation, again, how much in the healthcare system, considering our political economic factors, on how useful it is for our hospitals to be more autonomous, or the other way around, to be more closely linked to the procurement. 30% is in line with a single distributor. Only 30% is procured by hospitals independently. This balance should be.
So this balance, in my opinion, should be given a careful look. And the retail sales through private pharmacies, these are pocket expenses that often draw a lot of concern and outrage, especially when there is a spike in prices. The prices are not regulated artificially. On the one hand, it's a good thing because the markets should be free, but on the other, the patients should be receiving the drugs in a timely manner and in line with the expectations. That's all from me, and now I would like to give the floor over to my colleague, Kuchka. He would tell us about the international experience of reimbursement of high cost drugs and about the wastes, how they could be incorporated, and a special threshold of economic readiness. This is the most interesting thing. Thank you. Еще раз всем здравствуйте. Приведу некоторые примеры из разных стран на разные темы. Ну и поделюсь лучшим примером. Это Турция, на мой взгляд. Я буду говорить тогда просто следующий слайд, да? Поскольку кликера у меня нет. Да. Нужно упомянуть, что я нахожусь здесь при безусловном финансировании Novartis, поэтому хочу поблагодарить прежде всего их за возможность здесь выступить. Благодарю Novartis. Ну,
price for healthcare services, for pharmaceuticals, for medical device. In this industry, the price is not calculated from the cost of the production. It is calculated depending on the value that's served. Because already there's a big market there, and in this big market, actually, there are different alternatives. And each alternative comes with a cost. And each cost resulted with a clinical value. So the idea, the concept of this is willing to pay, actually. So the companies most probably make these kind of analyses and set the price depending on the value, not depend on the cost of production. So this is the different mindset than regular industry in the world. And these, how they influence, as I mentioned, value-based pricing, regulatory research, and all things are influencing the price, but actually in reality, everything, all the price setting is like, have you ever been in Grand Bazaar in Turkey, in Istanbul? If you have a chance, when you go there, there's no, yeah. When you go there, and when you want to buy a carpet, the seller asks you questions. What questions? First, he asks where you are staying. If you say Hilton, it's good. You will like to pay more. If you stay in a hotel just, around Eminönü, okay, forget about him. And then he asks again, for whom you are buying this carpet. If you say for me, you will never pay for it. But if you say for your love, yeah, you know, you buy your affair and you pay for your affair. And he's asked your country, you know, if you are coming from United States, yeah, you can pay more. So at the end of the day, there is no price. There is the price for you. There is no fixed price for this carpet because the price is already set under these conditions, under these questions. And pharma companies and medical device companies, I'm not blaming anyone, how they set this pricing. They set the pricing depending on the value, depending on the willingness to pay of the payers. So this is the thing that's happening every day in Big Bazaar, but it is happening in this big industry, a very oriental culture, but in a sophisticated way. And we say, wow, pricing. So I would like to give some examples from Turkey. Turkey is using international reference pricing from the 2006. We have a basket system, choose the lowest price from the basket system. And what's happening is this goes for the, and every year my company make a review of the price, and every year each company should submit the price change. Due to Turkey is getting lowest price from the given countries, Greece is has the majority. But also you can see that they are differentiated with the original price and generic price. So it is coming like that. And international reference pricing is also a good game area, actually. And if you plan in the international reference pricing, IRP, you can get the higher price somehow, because if the company plan for a large sequencing of the product in different countries in different time, then you can manage the price. On the other side, for the payers or for the decision makers, they feel that they are putting a price that all other countries are putting. So they feel they are in safety zone because this is the price, it's 500 euro, so I'm paying 500 euro as well. But is it right? I will come to this question answered later. Okay, how to reimburse high-cost medicines? Actually, innovation should be supported. As yesterday, our guest from US, he mentioned United States has the highest cost or highest price in the world. Because of that, you can see that all innovation launch in United States because nobody deal about the price. Nobody care about that. So this means the willingness to pay is too high. So if willingness to pay is too high, then innovation come to your table because they know that you are going to pay for everything without any question. Even $1 million, even $1. So nobody care about that, and do that, the innovation comes that. So the question is that, do you want to support the question or that? If you want to support the question, actually, there are different schemes that you would like to pay for them, but also trying to control for them, that I'm going to show on from the Turkish example. But here that we are already talking about, you can talk about health technology assessment, you can talk about patient access scheme, co-payments, like you can put some co-payment that US mostly using this, for example. Health technology assessment, we already discussed for the last day and today. But also you can make a, how can I say, special funding for rare diseases or orphan or oncology diseases. So here, the question again, how we can do that, I believe innovation is in there. But also, you need to care about the burden of diseases. Because if it is a huge burden for the society, the decision makers should try to solve it. Why? Because they are ruling the country, they are ruling the people. And if there's a high burden in the society, then they would like to solve the problem. in this case, as a company, for example, you have a chance to go for higher price because society is looking for the treatment and the decision makers has a push from the society so that they should solve the problem. In this case, the price may go up. Transparency and evidence base is the most important thing, I think. If you discuss about HTA and if you discuss about evidence, then your decisions may be the best thing. Acuity, I put it last, acuity, because nowadays, acuity is a common thing to discuss, actually. Maybe not 5 years ago, but nowadays, the acuity is a thing, especially for Kazakhstan and Turkey-like countries, because as all innovation goes to Europe and US, and we have less innovation, so it is not fair for us. So we need to somehow solve this with these criteria. Okay, how you can do a listing process in generally? But by the way, the listing process is nearly everywhere same. We just listened from Alima today, and also we just listened yesterday from Alex, Zafer. So it is same. You have a system somehow. Okay, there's a system as well in Turkey. There's a system as well in Algeria. Every country has a system for listing the product. But the idea is that do we need to consider different things than before, because we have a newcomers every time, and newcomers comes with a higher price. Think about that special conditions that I try to mention here: orphan diseases and value-based agreements. Orphan diseases. I believe the most unequated population is these guys in the countries like Turkey and Kazakhstan, or any emerging countries. Because, again, innovation comes, and these people, mostly, the innovation come to the rare disease area for the last couple of years, and people are suffering, and they cannot reach the treatment. So it is not fair from the humanitarian perspective. So I would like to give an example from Turkey. Turkey has a system, like your system, like Europe's system, what else? Everything starts with the regulatory process by Minister of Health, listing price set by Minister of Health, again. But then, who pay for it? Social Security. So Minister of Health set a price without caring about the low or high, and leave it to the discussion to the Social Security. So in this case, Minister of Health acts like a hero, because they are trying to save the patients, they are trying to make the access to patients, but Social Security, oh, they are bad guys, because they are not paying for that. They are not accepting price. So this makes Minister of Health in the safety zone and be a good guy. And Social Security be a bad guy, like bad police, good police issues from the US movies. So this is what's happening in Turkey. And when we look in the past 4 years, actually, around 50 new medicines approved and reimbursed in Turkey. It is not a bad number, actually, but it is not enough. Because at the same time, at the same years, in the last 4 years, around 200 new patented medicines approved by FDA and EMEA and launched in US and Europe. So Turkey only has 25% of them, 1 in 4. So I don't know what the number in Kazakhstan, but it is not good. There are 200 new medicine launched in US, Turkey only reimbursed 50 of them. It is not fair for Turkish people. But somehow we have a system. Also, when you look the ATC code, actually, majority is from oncology part or metabolic part, which are mostly orphan disease. So Turkey is a very famous country for price controls and other things, and everybody wants to understand how Turkey is doing that. Actually, Turkey is doing that with good policy and bad policy policy. There's a good police, Minister of Health, there's a bad police, Social Security, and they play the game with pharma companies. At the end of the day, okay, I believe it is not a success, but it is good for even we have 50 new patented original innovation launched in Turkey, one in a four than the US. Okay, I mentioned sickness funds. I believe this may be another interesting topic. It's available in the United Kingdom, it is available in Germany, it is also in Turkey as well. Maybe its name is different, there is no fixed fund Turkey, but when you go to UK or Germany, you see that there are some cancer drug funds, rare disease funds, orphan drug funds. Why they establish these kind of funds? Because normally, you cannot assess the risk of cancer or you cannot assess the risk of rare diseases. Because how you can plan or manage your country, because you should know the risk of your population epidemiology. But cancer and orphan diseases are not easy to estimate for next year because it may depend on the people's choice. So due to that, they separated these for a different fund. And what happened in this case? They can play the game with these funds. For example, decision makers, I believe this is the best idea for them because policymakers can play this budget and they use this budget in the elections. Just look UK elections and you will see that every prime minister says that I would like to increase cancer fund budget 20%. So this gives them a political power for their election, but also it gives people chance to reach the treatment. So it is a good system for that. And I would like to again give an example from Turkey. In Turkey, as I mentioned, we have not any fixed fund like UK or Germany, but we have a similar system for the patients who are suffering the treatment and who cannot get the treatment from Turkey or cannot cured with the treatment in the Turkey. So if a physician has a problem with the patient or patient has a problem and all the treatment option trialed in Turkey, all available one, the regulatory approved and reimbursement one, then physician can ask or request from Minister of Health for the specific patient and say that, hey guys, it is not approved in Turkey, but it is approved in US. And I need this treatment for Güvenç because Güvenç tried 10 different treatments in Turkey, available in Turkey, and he has only one option, it is not in Turkey. Let's think about him. What happened in this case? In this case, for the society, it is, for example, you are pumping a balloon, okay? The stress goes, and you need to just leave a little air from the balloon. Then the society calm down. It is something like that. People are suffering, but some of them get well. Then society has a hope. People believe that, okay, if I am suffering enough, at that time, the government has a solution for me. Okay, they are not approving 200 medicines in Turkey. I cannot access 200 medicines as a regular person, but if I cannot cure, then government has a solution for me. I may be a lucky guy to reach the remaining 150 medicines. So this is a good system actually for Turkey-like countries. I don't know, do we have a similar system? But this system is available in Russia, as I know, and also in Turkey as well. So, and these are the numbers that we analyzed in the last years, and it was around $3 million at that time in 2016. And from 2016, we don't know the numbers because government is not publishing, but this was the situation. So also we need to assess the opportunity cost. What is the opportunity cost? Okay, you have a limited resource, you need to spend $1 million, but if you are not spend $1 million, what is the cost? You need to know that as well, because if not spending $1 million is costly than $1 million, then you would like to spend it. So that you need to identify the alternatives, you need to assess the health outcomes, calculate the cost, and consider with a broader impact from the policy. Because impact of innovation is important. This is a good study, again from Turkey, and also it is a same study from Sweden, I believe, Liheimberg. Professor Liheimberg, he did the study, and also the same methodology used for Turkey as well. The study was first done for Sweden, and what they compared that if there was no innovation, what maybe happen for the life expectancy part and for the healthcare cost. And as you can see, for example, here, the idea is that Sweden is innovation supporting country, one of countries that. So you see that the life expectancy goes to 80. And they make a model and say that if we didn't make any investment to innovation, what maybe happen? They may lose 1 year, all entire countries. So, and also again, they calculate the same for healthcare costs. It's again same. They say if we are not pay for that, then we should pay more. And so also it was a study actually there. And as you see, in Turkish study, I couldn't put the graph here, but the idea was, in the same study, it was calculated for Turkey for 3 years. So supporting this innovation, even limited time, put Turkish people's life 3 more years in the last decades. So it is very important. So supporting the innovation, okay, it's costly, but at the end of the day, we have a tool that we can extend our community life. Okay, it is another discussion topic for threshold, cost effectiveness thresholds, actually. What is the threshold? Yeah, it is a very fruitful discussion because there is no ending for this discussion. You need to calculate the cost. Again, you need to calculate the cost effectiveness, and you need to calculate the threshold as well. World Health Organization has a recommendation somehow, but nowadays they are saying, no, we didn't recommend that. We just mentioned that. They changed their ideas, but it is there actually. But on the other side, the question is, okay, if we set a threshold, it's okay. Or, for example, in UK, there is no official threshold, but when you assess the previous decision, you can assess the threshold as well. So the question here from the ethical perspective of the threshold, okay, by the way, threshold is good because you can set a value there, and this value is transparent for everybody, and every product may know that they may get reimbursement or not. But the question is that if the new treatment's threshold is higher, far higher than your set threshold, what happened? Okay, in UK, because threshold founded by UK people, and they made an analysis, and they see that normally the threshold is around 40,000 pounds, but it goes to around 1 million, depending on the disease. What is the depending on which criteria? Most of the time it is orphan disease, because as I mentioned, the unequated population is the rare disease area. And when you go to UK, they have a threshold for regular medicines around 40,000 pounds, but this threshold goes to or has a plasticity to 1 million. So why they make this? Because at the end of the day, due to equity and due to their society, they extend the threshold. Okay, what is managed entry agreements? I believe you have a similar system, but you are using tender-based approach, as I guessed from yesterday and today presentations. Managed entry agreements are, again, think about you are in big bazaar. You know, it is just a bargaining process with the company and with the government. And believe me that, if you are talking about managed entry agreements, the price will be lower, not higher. But the idea is that the price may be confidential. Because depending on my experience from government, I worked in government, I worked in private industry, now I'm an academician and consultant. Depending on my experience in government and private sector, I can say that price is not the issue. The issue is it confidential or not? So if it is confidential, then companies are relaxed to discuss the lower price because the price is for you. Okay, they will not accept the very low price depending on the profit margin. Okay, I don't say this because every time there is a bottom, I know. But if the country, if the government secure their confidentiality, secure their products stay in the country, it is another thing, you know. There is a parallel trade issue, especially in Turkey as well. So if the government secure these two options, then companies relax and they accept low price. Okay, as I mentioned, not all price, but low price. Again, it is I have an example from Turkey. This is the analysis that we are mostly doing with my company. Turkey started market access agreement or market entry agreements actually in 2016. And in this, how many years? It passed 8 years. In the 8 years, 88 medicines approved through the market access agreements. It is nearly the half of the medicines that approved in Turkey for reimbursement. And when you look at, you see most of diseases are rare disease again, you know. And for rare disease and cancer disease, oncological products. And you know, especially before the pandemic, it was very great. Then pandemic slowed down it, and it is still move forward. But as you see, for the last couple of years, Turkey has an economical problem, so it is not good for the people as well. So managed entry agreements actually helps companies to launch easily in the country and help government to get more discount, but also support innovation somehow. And everybody is happy from my understanding because Turkey, with this agreement, secured the confidentiality and secure the stay of the products stay in the country, not go to the Africa or Middle East where the prices are higher than. So this is a good option that you need to think about it, and it is a very powerful tool, and it is in the game more than 20 years in Italy, Spain, Germany, France, UK. All the developed countries are doing that from the beginning of the 20s, this century actually, and Turkey catch this in 2016. I believe it may be a good option for you. Okay, these are my discussions, and if you would like to more, you can read my books that are on Amazon.com. If you have questions, I would like to, and thank you for listening.
Thank you so much, Guvench. I think that your presentation was excellent, and thank you for your exactly the specific focus on the situation in Turkey, because for our Kazakh audience and for our stakeholders, it's very important to know what happens exactly inside the specific country we would like to take for example. Уважаемые гости, слушатели,
Dear guests, dear audience, I would like to open the discussion. Can you please bring the mics? We have an open mic session. Revil, can you please give the mics? Thank you. Well, if you have any questions, we have, well, without 4 minutes, we have 40 minutes for discussion, for Q&A.
Presentation with facts. We have discussing our health authorities, Kazakhstani health authorities are discussing threshold, implementation of a special threshold like willingness to pay, which will be probably equal to 3 GDP per capita. And that's why I have a question about Turkey, especially for orphan and for oncological drugs. Do you have in Turkey such willingness to pay threshold? Because you showed interesting data about Great Britain, for example, and I think it is important to outline that it is not a way to use 3 GDP per 1 year for orphan drug, because most of such drugs much higher than 3 GDP. It's first question. And the second question is that many many stakeholders think that in Turkey very low price, medicine price, and it is true. And sometimes we have a question why we have not such prices in Kazakhstan. But as I know, and I just would like, can you please confirm or not confirm this, that if drug included in Turkish reimbursement list, it means that all eligible patients could receive this treatment. All who need, all who have prescription from doctor will receive this drug. Thank you.
Thank you for the questions. First, for the threshold, as I mentioned, there is not an official threshold from the UK. I believe countries doesn't need to put an official threshold, okay? But they need to mention, from my understanding, they are assessing the willingness to pay, or they are assessing the cost-effectiveness analysis. I believe it is more important than putting a threshold, because if the government puts a threshold there, a written threshold in legislation, you know, it's not good. It's not good for companies, but also it is not good for government as well. Because in some cases, as you mentioned and as I show, what about rare diseases? They cannot be catch any threshold. For example, for SMA, you know the SMA disease, yeah? The treatment is $2 million, you know? $2 million, how you can make a threshold with $2 million treatment? It is not possible, you know? It is not possible. So if you write this in your legislation, then you should follow the legislation. This means you will never pay for rare disease patients. So from my understanding, and also from the experience from the Europe countries, nobody defined an official threshold, actually. But you can assess the thresholds when you are looking at the previous decisions. It is the same in Turkey as well, depending on our experience. By the way, my company is also making these kind of cost-effectiveness analysis for the companies, actually, in Turkey, for reimbursement applications. And we saw that sometimes we calculate, as you mentioned, less than 3 GDP. Sometimes we calculated more than 10 GDP in some case. And even more than 10 GDP, but if it is rare disease, government pay for it. So it is something like that. I hope I answered your question. The second question, yes, if the product is listed in the reimbursement list somehow with a regular reimbursement or with the market access agreements anyhow, government pay for all the patients with the eligible criteria, because Turkish government put, for example, you get a regulatory approval with a broader indication, most probably. This is why, again, I can tell the story. The product is available with the given indication. It is, for example, lung cancer, and it is for lung cancer with PD-L1 inhibition, okay? Mutation, sorry. So it is okay for that. If, for example, they didn't maybe mention any after any treatment or before any treatment, something like that. But what Social Security makes, Social Security takes this indication and narrow it with the discussion with company. And if company is okay with the indication, and if the government is okay with the price, if everyone is okay with the patient, what percent of patient may be there with the budget impact, then the reimbursement starts. And when the reimbursement starts with the given indication or given criteria, if the patient is eligible for the given criteria, they can use it. You didn't ask, but you mentioned the lowest price in Turkey and why it is not happening in Kazakhstan. I'm not aware all your system in Kazakhstan, but what can I say? As I mentioned, Turkey get this lowest price because Turkey secure the confidentiality, actually. Turkey secure there won't be any parallel trade out of the country. Because original product cannot be re-export from Turkey. It is forbidden. You know, okay, people may do. It is a crime, by the way. It is crime because it is forbidden. It is in the law. If you do that, you need to go to judge and take a penalty. Even not only money penalty, you should be in the jail as well, a couple of years. So it is a forbidden thing. So do that. Companies are feel good to give the price. As I mentioned, okay, they have a bottom price at the end of the day, but they can go bottom, relax, you know, because they are sure that it won't be published. Okay, everybody talk about there's a lowest price there, but do you know which price? No, you don't know the price. This is the case. So you need to secure your price and parallel trade. Then it goes. This is what I guess from Turkey. Because before Turkey doing that, Turkey has higher price. I had analyzed I have analyzed about this, not bring here, but I can say that Turkey pay much higher price than Europe and US before implementing these policies.
Okay, thank you very much. I would like to continue in Russian, just one, two sentences, okay? In order to all here in the auditory will be on the same wave, okay?
My suggestion, Ayman, is that unfortunately we don't have key stakeholders. As Ministry of Healthcare, for example, they are not here to hear. We are discussing a threshold, and actually this might kill all the innovations for orphan and rare disease, for oncology medicine, and what our distinguished speaker just confirmed, I would say. Using this opportunity, since we are all here, we should be very cautious about these official thresholds, because we cannot treat everything equally, or, you know, it's not one size fits all. Well, thank you. Any other questions? Good afternoon.
You mentioned the two things when answering Ravi's questions about the confidentiality and penalty. I have two questions about the same things actually that you mentioned before. Cross-reference to each other's presentations. But the thing is, when we propose confidentiality about the price, there is always an argument, but how come this is public procurement? You know, people should know. There's this argument, and it kind of makes sense, you know, transparency, people should know, because otherwise there will be corruption, otherwise people will not know, there will be some way for, you know, other negotiations, bribes, kickbacks, etc. So what counter-argument that you can maybe were given historically or you can mention in this regard, because this may help in the future negotiate something simpler in our countries in the region. And the second thing, you mentioned parallel trade being restricted, but I wanted to mention that it's massive. It's massive parallel import. If you mention, for example, Uzbekistan, they're like, it's not thousands, like millions of drugs coming from Turkey each month. And you can go to the pharmacy and see the same price, I mean, same drug, local package, one price, and then the like Turkish labels, etc., a different price. Obviously, they sell it illegally, so they don't give you a receipt for that for those kind of medicines. And most of the time, consumers don't really care because they see it's the same kind of genuine drug, looks like the same. And obviously, it's the problem of both countries. The one that is kind of illegally exporting because it's a crime, and of the country that lets it be imported and sold. So, but we're not talking about what is the government, for example, in the region, that we, I don't know, Uzbekistan, Kyrgyzstan. It's less of a problem, I think, in Kazakhstan, but still, Tajikistan, yeah, what they're doing. But I was curious to, again, if you could expand, in addition to just mentioning it as a crime, what actually Turkey is doing to restrict it. Is there any like meaningful, practical program in addition to just, I don't know, punishment? So just two questions about the confidentiality of price and the second one, parallel trade. Thank you.
Thank you. Yeah, actually, confidentiality of price is a debate as well in Turkey, depending on from the transparency and other things. But it is not a discussion from the corruption part, but it is a discussion from pharmacy part. You know, because pharmacists sell the medicine to patients or to the social security, actually. They invoice to the... In Turkey, we have a retail pharmacy system. Medicines are available in retail pharmacies that are reimbursed by government, and pharmacies gives the medicine to patient, but they invoice to the government. So in this case, pharmacists are arguing this system because they say that, okay, I don't know how much money I'm going to earn this product because I don't know the price. So you make me a trade man or woman, but you don't let me know how much money I will earn from this product. You know, it is not fair from their perspective, and I totally agree with them. In Turkey, this is the debate right now, and actually what did Turkish Pharmacists Association go to the court for this claim, for transparency claim, and they won. They won, definitely. They won, and due that, I didn't mention, due that, as you see, the numbers was falling down in the last years, because in 2023, in the mid-2023, they won the court. And then the government could not move forward with the legislation. But what happened? 3 months later, they published a new legislation. And in the legislation, they make a very clever idea, and now they cannot go court for this claim. But I believe it is a big debate. I don't have any right answer for that cause. But what can I say that all the Turkish government procurement, okay, it is not published, definitely, officially, this kind of medicines, but all the system is every year assessed by the Sayıştay, we say, the higher economic evaluator court of Turkish government, and they publish the reports, actually. In this report, you may have chance to see the price, actually, but it is not the official price, you know. So if you go to Sayıştay reports and go deeply, it is there, actually. But it is not official, because it is the report of Sayıştay, you know. So do that. I don't have any issue with the corruption, because another government institution evaluates social security, not only social security, all government institutions, and publish reports annually or biannually. And in this report, you may have chance to see the price if you look to the right price. But it is not the official price, so nobody cares about this. It is the price that published by Sayıştay, not social security. So this is the one trick that Turkey is doing, actually. So, the second question about the parallel trade. Turkey has a drug tracking system. Each unit of medicine, each box, has an identical number, has an ID, like your social security number, your government ID number. Each unit of box. And pharma companies are responsible to produce these numbers because there's an algorithm and they produce the number and they define the number to system. So that each box from company to the patient are on track on the system. And companies are not seeing which patient takes the medicine, but they see that where is the medicine that they sent to the wholesalers. In which wholesaler, in which pharmacy, is it sales, is it sold to the patient, or it is still in the pharmacy, they can see it. So this gives the companies confidentiality, comfortability. They can see it. If they put the barcode, they can see where their each product. It's a very good system. But yes, there are people that abuse the system. How they abuse? Don't let me to tell the story, but yes, there are some open gates, actually, as every system. But in reality, what happened, if, for example, if a pharmacist buy the product from wholesaler, but not sell the patient, then they cannot out the product from their system, because you should enter the barcode of the box, and you should enter whom you are selling, Güvenç Alima, name, ID, you know. Otherwise, you cannot, how can I say, decrease your stock. Yeah. And what happened, there are some pharmacies, they have stocks, 10,000. In reality, no unit of product. So actually, this legislation come just a couple of years ago, 3 years ago, I believe 4 years ago, for the parallel trade ban. There is no court actually right now, but people know that there are some pharmacies, their stocks are there is no stock, but in the system they have stock. So what happened, we will see, actually. But first, they will get a penalty from the Ministry of Finance, because in reality, they didn't sell it, but they sell it. But they didn't report to sell it, they didn't pay tax. So, and the tax penalty is waiting for them. But we didn't see anything yet, because it is just a couple of years this ban come on board. Before this ban, they can mention, okay, I sell to Kazakhstan, I sold to Uzbekistan, I sold to Dubai, they can mention anything. But then now they cannot mention this, so the system is running something like that. Yeah.
Thank you so much, Güvenç. This was quite interesting to listen, to hear about the situation in Turkey, and I see some sophisticated ways, like when sophisticated mind, I mean always sophisticated, when they create something with like some pathways for their interesting, like not good maybe things. Yeah. Благодарю за вопросы, уважаемые.
Thank you very much for your question, dear participants. I hope our wonderful, honorable guest tried to do his best to disclose the situation with the medicine supply in Turkey. Are there any questions? Yes. Hi, everyone. I hope you can hear me. I wanted to go back to the willingness and readiness threshold to support the concerns of Ravil, because sometimes if it's 15 million tenge, we can satisfy it. But if this is not even yet orphan. But when we talk about oncology, what will we see? What we will do with the combined one? There is a new agent coming in on the market. he extends life for 7 years. This is just a hypothetical example. 6 months is already good enough in oncology. So the new agent comes in, extends the life by 7 years, and it costs 3 million tenge a month. And the existing therapy remains, and it requires additional administering effort by infusion, and then a month. This new therapy, this hybrid, this combined therapy, would amount 5 million tenge multiplied by 12. How much we get it a year? 60. It will never make it to 3 GDP. It will never fit it. But the new agent would allow to extend the life of a human by 6 years. So the level of readiness is, I think, very useful from the standpoint of proper assessment of HTA. How to assess, bottom, floor limit and ceiling limit. If Kazakhstan introduces such a diversified scheme like in UK with 20,000 pounds, 100,000 life, and up to 1 million for an orphan ones. And when we're talking about combined therapy, there were some experimental calculations done, and they were lowering the price of new agent down to 0. However, still the price of this therapy, of the new medicine, would exceed the readiness threshold to pay. Okay, let us clarify the situation for everyone. Naturally, when it comes to this type of issues, there should be a proper HTA study with an economic component, cost effectiveness analysis, maybe along with other pharmacoeconomic analysis components. And maybe on that note, I would like to ask dear Güvenç to tell us about opportunity costs. Because in our country, we have a trend to calculate costs. We do ingredient analysis. We do some kind of accounting. We all tend to be good accountants, but we're really bad as economists, because accountant is an accountant. He tracks, expenditures, the income, debit, credit, while an economist, a proper, true economist, not the one who says, here is 5 million for healthcare, and this is how much we spent, and so on. This is not a true economist's job. An economist is capable of assessing and analyzing the environment and modeling and creating a forecast of some sort. And when we start speaking about costs, we always divide it into healthcare, non-healthcare. This is purely accounting, but we want to be good economists, and for that we need to realize what is opportunity cost, what are the expectations, what kind of revenue we could have. I think it's interesting for government overall.
More ideas and insights about opportunity cost, because people sometimes don't understand what does it mean.
Yeah, sure. Okay. So actually, opportunity cost is one of the things that you need to think about. I believe it is hard to calculate because it is very hypothetical, and it is how you start is another question. So it is a hard calculation or method, or you need to find out. But the idea is that you need to think about it, definitely. You need to think this concept, and every time your question should be, what happens if I don't pay for it? So this is the question. I believe every government officer should ask for that. I totally agree with you. If there is a treatment that extends the 6 years of the patients, brilliant. How we can assess the life and with the money? Definitely, totally agree. But as I mentioned, there is no official threshold in any country. None of the developed countries, even or emerging countries, they never put a threshold, official threshold, because official threshold, putting an official threshold is not feasible for government and for companies, as I mentioned. So if something's happening like that, all of us, all of you should be against for that, because it is not good for government as well. Because you should give the government this message. Okay, you put a threshold to the legislation, and there's a new treatment. And if the society demands this treatment, they go to the street and make demonstration. I don't know if it is happening here or not, but it is happening in Turkey sometimes. You know, especially if it is for children, if the treatment is for children, people are going to the street and they are crying, they are demonstrating because they want the treatment for not themselves, for their kids. So if the kids come on board, how we can say no for this, especially for these treatments? So I think this is the most important thing, that there should not be an official threshold. Okay, you can assess this threshold for the 3 GDP or 10 GDP. This is what's happening actually in UK, and we can see that their decisions are more than 10 GDP in orphan disease or in oncology disease as well. Because it is not possible one size fit all. It is not possible in this case. So another example, maybe actually, I can say another thing that I can say, that this is a culture issue. It is a culture. Let's give me an example from United States. In the previous election that Trump elected against Hillary Clinton, what Trump said in TVs, or what senators say from the Republicans, they say that why we are paying for the people who are not paying taxes. They support this idea. They say that why we are paying for the medicines that people who are not earning money, who has less money and less tax to pay. I can't think that any Turkish politician can say this word openly, in publicly. But they made an election campaign focusing and saying that we don't pay medicines for the poor people because they are not paying tax. So can you imagine this happening actually in US? And everybody say, yes, we don't need to pay for poor. They can die. So can you say that in Kazakhstan? No, in Turkey. So all the things are culture, and every country has own culture and own decisions. So we cannot one size fit all. Yeah, this is what I can say.
Great examples, thank you. Так, еще вот ваш вопрос, ответили на ваш вопрос? Да, Нургуль Сульбановна, ага.
Thank you very much, dear Givench, for this fascinating presentation. I would just like to share my feedback and maybe ask a question. As you know, in our Republican Healthcare Development Center, we used to have a working group for outpatient medicine supply. And there were recommendations submitted to the Ministry of Healthcare on introduction of this payment readiness threshold, so that it wasn't universal but could be 3-level standard for a high price and another one for orphan drugs. Because we all know that we incur huge costs for these orphan drugs, orphan disease medicines, but there is still a lot of needs that are not satisfied. I would like to ask, what share of the budget in Turkey goes to support the patients with orphan diseases? Because we know that annually half of new drugs are registered, particularly for diseases in that field, for orphan diseases. So I think if the trend remains the same, the number would only rise. And how do you see this issue could be resolved in the future? I think this is relevant not only for Kazakhstan, but for others as well. And we know that many orphan medicines and drugs, they registered based on this indicator, and then they have some non-orphan indications. Do approaches in Turkey differ in terms of making decision on selecting a drug? A truly orphan that has only one indicator, or not purely that has many other indications?
Not exactly off-label, but for some drugs.
Off-label.
Not exactly off-label. They might be registered. They might be registered, but they have some different.
There was a suggestion also made to use a combination for orphan drugs, as it's done in many other countries. Is standard economic and MCDA, the one that actually Turkey is applying. Thank you.
Like MCDA plus standard cost. Possible, and in Turkey, kind of this maybe combination of approaches are used.
То есть уже и разработаны примерно критерии, то есть их, которые желательно было бы.
Yeah, I'm just interested in the criteria that we.
First question: what amount of money we are spending in orphan disease area? Actually, when you look the last 2 decades, Turkey's pharma market nearly quadrupled time. It was $2 billion. Now, last year, it was around $8.5 billion last year. Total pharma market. Plus supplements, and so it goes to $10 billion around. When you look to $8 billion, as I know, $5 billion goes to the patented products. The $3 billion goes for generics and everything. But in this $5 billion, it is not only the patented, how can I say, it is patented, but there may be some generics as well, but it is patented. For the orphan disease, I show some numbers that we evaluate in 2016, not today, because we cannot see some transparency things, as I mentioned, the market access agreement and things. Now we cannot see all the things, but at that time in 2016, the Turkish market was around $5 to $6 billion, and orphan diseases may take $400 to $600 million. So it is nearly 8 to 10% of the total budget. And it is normal, because in it there are not only orphan, because in orphan you mentioned, for example, some oncology medicines are also orphan, because the oncological indication is too rare. So it is not only orphan, it is also including some oncology patients as well. Yes, definitely. As I mentioned, you mentioned that can we do some differentiated models for defining that? Definitely. So, and as I mentioned, it is not possible one fit all. You cannot just directly take UK model or Turkey model, because it is not the country that you are living for. You know, it is a totally different culture. In UK, for example, you cannot go court for NICE decision. You cannot go court. If NICE say no, nobody can go court against this. But in Turkey, everyone can go for Social Security's decision. If they say no, I can go court, say that, okay, it's not fair. I have scientific proof. So, you know, it is totally different. And you think that UK is more developed and more legislative country, but you cannot go court. Okay, but Turkey is less developed, you know, but you can go court. So how we can assess this? But definitely MCDA should be in the game. Actually, what Minister of Health published in Turkey last year, Minister of Health of Turkey published MCDA methodology, algorithms and the calculation method for orphan disease. It is not implemented yet by Social Security, but I guess they will do. Because it is very good for everyone. Because with the MCDA, you can categorize the medicine, okay? In this case, you can mention the old medicines are not good for patients, and then you may stop to pay for it. And you get this budget to here for more effective medicines. So MCDA should be in the game, and Turkey is moving for implementing MCDA, that I can say, because Minister of Health published the guideline just last year. I believe in a couple of years we will see MCDA studies from Turkey, and Social Security most probably implement MCDA, especially for orphans, because there's a guideline there. As I mentioned, we have a good police, bad police. It is another trick in Turkey. You know, not take all the things in one side. So in this game, the government is say, okay, it is Social Security's deal, not my deal. Hey, it is not my deal, it is Minister of Health deal. Sorry, I'm waiting for guideline. So, you know, so it is but it is Turkey. And Turkey, this is why it's come. Think a country, we are in a war, the Russia and Ukraine war. Think a country, only airplane come from, if you want to go from Kiev to Moscow for peace, you should arrive Istanbul first from Kiev, then change your flight to Moscow. This is the only country that's doing that. You know, this is the only country now, bad police, good police, same for Turkey. It is a culture in Turkey. And the only country that you can fly to Russia or Ukraine, not UK, not Germany. Istanbul. So it's just Turkey. Yeah, so this is the culture, I believe so.
Thank you, Гвенч. У нас осталось 8 минут, поэтому если...
Well, we have 8 minutes left. If there are any short questions, please go ahead. But we cannot spend more time to that. And I have a question. A question about production. Is there legislation in Turkey for the generic producers that they should pay, that should be selling less expensively? They should be selling cheaper compared to the original drugs. So for generics, is there such optimization possibility to require the generics producers to sell for less?
Actually, Turkey has a market, or Turkey's manufacturers are mostly generic companies. Due to that, Turkey's price policies are not against generics, because they have the local manufacturer. They don't want them to be bankrupt. So in Turkey, generic pricing scheme is in favor of generics, that I can say you. The government, okay, there's a mandatory price decrease when generics come board. It is 40% or something. And yes, Turkish government pays for the minimum generic plus 5%. So if, for example, if the minimum generic is 100 Turkish lira and your product is 110, then the patient should pay the 5 Turkish lira and get the product. So these kind of policies are on board, but in reality, when you look, there are analyses. My partner, Professor Çalışkan, he made an analysis about that. And what he found, Turkey has low price in originals, but high price in generics than Europe. We are in Turkish lira, they are spending in euro, and we are paying more to generics, less to originals. Because why? Because we have a industry just doing generics. From my understanding, and what happened next? Okay. Maybe it cut innovation, okay, I don't say, but what happened at the end of the day? Okay, Turkey has a lack of, or not delays for launching the medicines, new medicines, but at the end of the day, the original companies launch their medicines in Turkey. Why? Because they can protect their price as well, even generic come on board. Because, okay, they are imported products, okay? New generic come on, local manufacturers, but Turkey never say, I will not reimburse the original one. Okay, they try sometime, but now they cannot do that because it is against the World Trade Organization things. So due to that, they can stay in the market, okay, with a lower price, but they can sell the product in this price. When you go to Germany, you see that generics price dropped nearly 90%. If you make it a free market, generics compete with them just on the price. Then it goes to 10% of the original price. And original company, for example, Novartis, Pfizer, they cannot sell their original product in Germany because of the generics, but they can still sell their product in Turkey because of the favor of generic price policies, because they can protect the price and they have a still maintaining business and they can earn money. So this is why in Turkey we see that companies somehow would like to launch it before of patented. They launch on patent, but at the end of the on patent, because after off patent, they have a lower price, okay, but not lower than Europe. And they still earn money. And one of my lecturer, again, I would like to mention his name, Monder Tami, he said that this is the cream on the cake. The companies take the biggest portion of money from Europe and US in the time of the patent, and they launch it in Turkey or similar countries, and with the generic pricing policies, they take the cream from Turkey. So it is good for, I believe, Turkish system and Turkish companies as well.
Okay, got it. Just preferences for generics, but if it's the same for the INM, for the same dosage, for the same working component, do I understand correctly that generic can be more expensive in Turkey market? If we are comparing just Turkey, government is ready to pay more for the locally produced generics rather than to the original drugs, or no?
It is not possible due to legislation, but it may possible with the market conditions. And yes, for example, because each generic has its own brand. In Turkey, we have branded generics in retail pharmacies. They have their own brand, like an original product. So sometimes we see that patients, for example, if it's a chronic disease, they used to get the same box. So if they stick on this box, there was one example, as I remember, the generic is higher than original in sales and in price, because they made a good branding activity somehow, and patients are stick on brand, and they are expensive than the original one. But normally, there is no legislation about pushing down the price for original, because it is not fair for World Trade Organization legislation.
Thank you, Гвенч. Уважаемые слушатели.
Dear colleagues, that is the end of our educational symposium. I would like to thank you for your attention. Thanks for active participation, and I hope you will support our YouTube translation, YouTube broadcasting. More likes we have, better coverage we have.
Thank you. It was great. Thank you.
Раз, 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 два, три. 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 Раз, два, три.